Today on this episode of The Brain Surgeon's Take, we will be discussing whole eye transplant moon shot with Professor of Ophthalmology at Bascom Palmer Eye Institute, Dr. David C., as well as scientist and biomedical engineer, Dr. Daniel Pelaez. Learn about this ambitious research initiative aimed at transplanting an entire eye, including the optic nerve, with the goal of restoring vision in blind patients. As you can imagine, this project has immense scientific and technical challenges. Much more on this podcast episode. Welcome back, everyone. Here's my take on Dr. David C. and Dr. Daniel Pelaez. They are pioneers exploring the frontiers of science, medicine, and innovation, as today's podcast episode takes us into a field that was once thought to be science fiction, but is now edging closer to reality, the possibility of a whole eye transplant. David and Daniel are both world-renowned leaders from the Bascom Palmer Eye Institute, the #1 eye hospital in the world. Dr. David Z is a specialist in ocular oncology and orbital surgery. His groundbreaking work has shaped modern approaches to treating complex eye diseases. And alongside him, Dr. David Pelaez, a distinguished surgeon scientist whose expertise bridges cutting-edge clinical care and transformative research. Together, they're part of the bold effort often described as a moon shot, a mission to restore vision through transplantation of an entire eye. We'll dive into the science, the challenges, and the hope this work represents for millions of people living with blindness. Stay tuned as we explore what it might take to turn this extraordinary vision into reality. Listen up as we discuss whole eye transplant moon shot. Check it out. Hey, David, and hey, Daniel, how are you guys?
Great. Good morning.
Great. Morning.
Very excited to have both of you on this podcast as leaders in the field, talking about Bascom Palmer's Moonshot Whole Eye Transplant Project. I find the entire concept fascinating and look forward to your input.
Well, thank you for having us on. Looking forward to the discussion.
Absolutely. Well, I guess, where did this idea originate? What inspired the idea of pursuing a whole eye transplant?
Well, it's interesting. The technical triumph of the face transplant really proved that impossible is now possible, and really invoked the imagination of the scientific community. So I as an orbital surgeon, deal with the optic nerve quite often, particularly traumatic optic neuropathy. So our lab is dedicated in finding a solution in treating traumatic optic neuropathy, in which effective therapy remains elusive. So, and it's just a very analogous application to whole eye transplant. The transection of the optic nerve and reconnecting it is an extreme form of traumatic optic neuropathy. So in our lab, we have been working on neuroprotection for traumatic optic neuropathy, finding solutions to address the traumatized optic nerve. So what we have learned in our animal model, the molecular underpinnings of traumatic optic neuropathy, basically we apply all those other principles that we have learned in traumatic optic neuropathy in designing our preservation of the whole eye transplant. So it's very analogous and very closely related entity. So, there are only 4 organs in the body that have never been transplanted: the brain, the spinal cord, the hearing apparatus, and the eye. So it is the last frontier in ophthalmology. And since we're working so closely with the optic nerve, it's just a natural extension to an area that we are familiar with as an orbital surgeons. So we distinguish ourselves by not doing the eye facial transplant composite, rather than confining to orbit-centric eye transplant because we know the anatomy, we know the physiology of the eye. So I think it's a natural extension from what we are doing in research. So.
Hey, Daniel, maybe you could tell us a little bit about how you got involved in the, on this project, and why is Bascom Palmer so uniquely positioned to do this moonshot project?
So the way that I got involved was 10 years ago, Dr. C had this vision to establish a translational research facility that would include regenerative ophthalmology. I'm a bioengineer by training with a focus on tissue engineering and regenerative medicine using stem cells. So I was already working on regenerative medicine in the sense of cellular therapy, cellular replacement therapies, where we could replace parts of the eye, say the retina or the back of the eye, the RPE, in a tissue dependent manner. When I joined the program and Dr. C spoke to me about this idea of transplanting a whole human eye, uh, I was on the same boat as most people that are probably that learn about this for the first time, that they say this is going to be impossible. Then he started talking to me about the surgical approach that he had designed and just the feasibility of the surgical approach as the way that he had envisioned it gave me the hope that this was closer than I had imagined before, where maybe transplanting or replacing the entire eye would be a more feasible concept than trying to replace different tissues. So based on what we had learned in the lab and what Dr. C just spoke about in our studies of optic nerve regeneration following trauma, I say it combined with the surgical aspects that he's already developed, whole eye transplant then became a possibility, a reality in my mind that we should definitely pursue. Now, Bascom Palmer is uniquely positioned to tackle this, one, because of the breadth and depth of expertise in surgical approaches involving the eye and the orbit. Dr. C is a world renowned orbital surgeon, where he developed all these surgical workflows that nobody had thought about to make eye transplant a lot more feasible from the anatomical and surgical perspective, but also because Bascom Palmer has a very unique environment in which the intermingling and the cohesiveness between the surgical or the clinical aspects and the research aspects uh, are not seen in many other places, right? A lot of people that do vision science, or a lot of the other departments that do vision science, are not integrated with the clinical aspects of ophthalmology. So these are done in neuroscience departments or cell biology departments outside of ophthalmology. Here we have within the same building both clinician scientists as well as basic researchers working hand in hand to tackle some of these most difficult, challenging problems.
Now, I had the same reaction that you had, Daniel, when I first heard about this. Like, that's never happening. And I think, people think about corneal transplants. Obviously, that's done successfully, it's done commonly, but this is obviously a much bigger project. And maybe you guys can go over what are the biggest biological hurdles? I mean, you're thinking about vascular, neural. uh, How do you overcome these challenges?
Yeah.
Well, maybe I can take the first shot at it. And well, there are four major hurdles from my standpoint in terms of developing a whole eye transplant program. One is a technical feasibility, and to recover an eye and preserve the eye to address the physiological challenges, and then how to put the endings of the ends of the optic nerve together, the coaptation, overcoming the this is a major biological barrier, and then finally the immunological challenges. So our workflow is geared toward one, to safely recover the eye. The key is that the eye is so unique in that it's very intolerant of anoxia. So the first thing is in the recovery process is that we want to make sure from the moment of severing the blood supply to the eye that we need to maintain oxygenated perfusion constantly to the eye. So the design of that is to access the internal carotid where the ophthalmic artery comes off, and then cannulate the internal carotid artery with a designed miniature eye ECMO machine, so that we can perfuse the eye constantly, and then design a perfusate that is necessary to provide sustenance to the retina. And that knowledge came from our works in traumatic optic neuropathy. So that was important in applying that. And then finally, from an orbital surgeon standpoint, when you put the nerve endings together, the major tissue reaction is gliosis and scarring at the coaptation interface. So much of our early work was to design a compound that would retard the gliotic response, and then also try to promote axonal outgrowth, and so that's part of the scheme that we have put together. And then finally, in thinking ahead, in the insetting of the donor eye to the recipient orbit, we preserve all the extraocular muscles, we preserve the cranial nerve 3, 4, 5, and 6, so that after putting the donor eye into the recipient orbit, the eye can move, then the eyelid can blink and close as well. So those were the anatomical considerations in designing this whole workflow. The key, the hallmark of this entire design is that there was this constant oxygenated perfusion to the eye. There's no momentary lapse of perfusion to the eye.
Daniel, I wanted to ask you, the part that, as a neurosurgeon that I find the most intriguing and the most baffling is how are you connecting that optic nerve, and what progress has been made in either animal models or laboratory studies to get these optic nerves not only connected, but functioning and sending signals?
So yeah, and most of the people that hear about this have the same qualm, right? That is the main biological hurdle. There's, as Dr. C explained, the 4 organ systems that have never been able to successfully be transplanted all contain components of our central nervous system, right? And in the eye, we're talking about the retina and the optic nerve, which you can think of basically extensions of the brain. These are structures that normally don't regenerate in humans. However, if you look at the whole of vertebrate biology outside of mammals and birds, central nervous system regeneration is actually quite ubiquitous and it's quite spontaneous. So one of the things that we've done in the lab in studying traumatic optic neuropathy is also learning from lower vertebrates as to how they respond to these injuries and what mechanisms evolutionarily we evolved or diverged from that allowed us or prevented us from undergoing spontaneous regeneration. And I'm very excited to announce that in the lab, modulating several of these mechanisms, we've been able to show very robust regeneration in a transection model in mammalian species, in the rats specifically, that allow for these axons to traverse the transected optic nerve long distances and reinnervate parts of the brain. So learning from biology, learning from nature as to how these mechanisms occur and how they differ in the species that actually undergo regeneration failure is one of the hallmarks of our program that allows us to envision this actually happening functionally in the future.
Now, what would you say are some advancements in technology that have made this feasible in the last 5 or 10 years? I mean, are you guys using AI? Is there any new microsurgery or advanced imaging that you guys are using for this project?
So we use a lot of advanced imaging for assessment of both donor and recipient uh, viabilities as well as integration. We use a lot of advanced imaging to assess the donor eye functionality outside of it, after it's been recovered, to make sure that the transplant becomes more successful. Microsurgical techniques, and Dr. C will speak a little bit more about this, are critical when you're working in such a confined space as the deep orbit and trying to coapt the optic nerve or the vessels in the apex of the orbit, which is a very confined space. AI helps us also identify a little bit of the covariances and the confounding variables that may hinder or may promote one graft being successful over another. And we're working with AI models to train them on this. I don't know if David has anything else to add on that side.
Well, microsurgery certainly, the advances in microsurgery clearly help us in this project. But we're exploring the use of robotic surgery for optic nerve coaptation in the depth of the apex of the orbit. But innovation emerging from this project is that the use of polymers. We developed a polymer vascular stent to connect small vessels, and that is the anterior ciliary artery in each of the extraocular muscles responsible for perfusing the anterior segment. The diameter of that vessel is about 200 micron. So, and it's very, very hard to connect the vessel in each of the extraocular muscles. So the use of this special polymer stent that prevents thrombosis and fibrosis would be, it's a major advancement that is being exported to other surgeries right now.
Two other kind of hot topics in medicine in general that are really pushing the frontier forward: gene therapy and stem cells. Are those playing a role at all in how you approach this project?
Yes, absolutely. So I spoke about some of the mechanisms that we've identified that lead to regeneration failure in mammals or in primates. So we've been able to apply gene therapy to modulate some of these mechanisms and show conclusively determine that they are the ones responsible for regeneration failure. Obviously, if we could get around it with a pharmacological approach, that would be ideal, but that's probably years down the line. So, gene therapy is probably the most viable option right now to coax some of these regenerative programs in the coapted optic nerve. Um, and we're exploring that heavily in the lab in our animal models in terms of gene therapy for that. And stem cell biology, if you think about developmental biology and stem cell biology, all these processes happen early on in development, right? So the optic nerve naturally grows. It's with age and epigenetic mechanisms that these programs get suppressed in the adult human body. So looking at stem cells and how stem cells originally formed the optic nerve have informed part of these mechanisms that we've studied. Now, other groups have looked at whether applying stem cells, neurogenic stem cells, into the interface of the coaptic optic nerve, whether that creates a more permissive environment to prevent the gliosis and promotes axonal regeneration. And there's other groups also looking at whether you can generate basically a bridge, a neuronal bridge out of stem cells to connect both cut ends of the optic nerve and that way get the signal across the transection plane. We've explored all of those in the laboratory, but finally we've focused on the molecular mechanisms through which stem cells naturally give rise to the optic nerve and that we can modulate through either gene therapy or pharmacology.
Very, very interesting and cool how you guys are kind of incorporating all those different frontiers. Now, who would be the ideal first patient for this eye transplant? And then how do you temper their expectations to make sure they realize that this is experimental?
I think the ideal first patient would be someone who's bilaterally blind. Because one of the major concerns in transplanting an organ is sympathetic ophthalmia, where the autoimmune system of the recipient would begin to attack the donor tissue in so doing, indirectly affecting the contralateral normal seeing eye. So we don't want to subject the normal contralateral eye to this kind of problem. So would be a bilaterally blind patient first. So we have to manage the expectation because there are a lot of things still are unknown, like neuroplasticity, for example, that we still don't know much about. So I think that the expectation at the beginning would be if they can improve on the circadian rhythm as a result of transplanting the eye. That would be a major first major improvement in improving the life of the patient.
Yeah, that was a good point you just brought up, and maybe Daniel can kind of just elaborate on it. How much vision are we talking about when you do an eye transplant, right? People are going to be like, "Oh, it's 2020 and you could be a Air Force pilot." And you're talking about circadian rhythms. How much realistically would this eye transplant, what kind of vision would that person expect to have?
I think that's still one of the big unknowns, and
Yeah.
that's why tampering expectations, as Dr. C just mentioned, is one of the key factors in adherence of patients to undergo this procedure, as well as in our own expectations as to what the outcomes may be. So focusing on lower level inputs and determinants of visual function, such as circadian rhythms, would give us an indication as to innervation of the correct visual targets in the brain, and then from there on in, the amount of visual information that can be delivered to the right centers and how it gets decoded. As Dr. C said, neuroplasticity remains a big unknown here as to how the human brain, the adult human brain, would adapt to new innervations in terms of visual processing is still a big unknown. So we don't know yet what to expect there.
Yeah, I think people are gonna need to realize this is, we are moving in the right direction, but we're still a ways off. And you guys are both at Bascom Palmer, but obviously the first eye transplant is going to require multiple specialists beyond just ophthalmology. I mean, talk about the role of the neurosurgeon and the immunologist, just like David was saying about having an autoimmune response. Who else is going to be involved, and what other teams need to participate?
We have a biomedical engineering team to help us manage the ECMO machine and maintain the perfusate and to analyze the molecular response to the transplant. A key about this setup is that we can have a real-time assessment of the immunological response as the effluent fluid coming out of the eye. We can test the immunological response in the beginning and react to it in real time. So those are the steps that we're trying to manage uh, immune tolerance.
Yeah, to give you a more broader answer to your question, our program right now includes 18 different faculty from 7 different departments. So that includes biomedical engineering, as Dr. C just said. Obviously, neurosurgery plays a big role. Plastic surgery in helping us with some of the microvascular reconnections, transplant surgery, as well as immunology, all play a big role in the different aspects of this project.
It's obviously an immensely expensive project. You're talking about something of this scale and this magnitude obviously requires a lot of funding. What are your resource challenges?
Well, there's an Arabic saying, say the heaviest luggage before a long journey is an empty wallet. And so much of our research uh, is based on philanthropic support. And the lab was funded by a grateful patient. So that was the start of this project. And then subsequently, other grateful patients continue to support this effort. More recently, Upper H through the THEA program is sustaining our research effort for the next few years.
Yeah, I mean, just goes to show the importance of philanthropy. I think that people can't really underestimate the importance enough. And obviously, ophthalmology, neurosurgery, I always stress that to my patients that, philanthropy is really the engine that drives advancement. So I'm glad that you guys have grateful patients that can push this forward. Are you guys collaborating with other institutions or research centers around the world?
Oh, yeah, absolutely. So, at least under the THEA program, there's four performer teams that have been funded to pursue the different technical areas of these, and we collaborate with all of them. So we are very open in sharing our knowledge, sharing our approach, and learning from them to see what synergies may exist to be able to, as a community, move this project forward as fast as possible.
Yeah, I mean, it seems like even though Bascom Palmer is the number one eye institute in the world, the more people involved, the faster this will get done. And along those lines, realistically, I'm going to ask both of you: when do you think the first human whole eye transplant will happen? Realistically, all right, because there's what you want and there's what's reality. But in your minds, if you had to put a number on the year of when you think this will happen.
Personally, my timeline is next 5 years.
Good. Yeah, so my timeline originally when we started this project would have been maybe 10 years. After having done a couple of the recovery procedures and seeing how successful we are and knowing what's going on in the laboratory, I think within the next 5 years we'll see the first one happen.
I
That
think
would be
the next step is for us to advance to a primate model, a proof of concept of all the developments we have made.
Yeah, how close are you guys to getting into the primate model?
Hopefully, in the next 6 months.
Yeah.
Wow,
We have
that's
the
fantastic.
protocol already written out and we're ready to start.
Wow, super exciting. Beyond restoring vision, which is obviously the main point of this project, could the science behind the project advance other areas of medicine? Is this bigger than just an eye transplant?
Absolutely. So when we're talking about mechanisms that promote or elicit central nervous system regeneration, you can think of the optic nerve as, like I said, it's an extension of the brain outside of the skull, just as the spinal cord is another extension of the brain outside of the skull. So analogous structures, the optic nerve and the spinal cord, our ability to regenerate the optic nerve will inform and ideally promote and help people with spinal cord injury also regain function and regenerate that structure.
Yeah, landing on the moon is the final destination for us, but it is the spin-off discoveries that will benefit other subspecialties. For example, the uh, the polymer stent, and also the maneuver to retard the gliatic response at the interface. That would be a helpful discovery. And the drugs that would promote axonal growth, uh, drugs that are peptides that can retard the repulsive cues that Daniel Slab has discovered. Those are advancements that will benefit uh, ophthalmology and other subspecialties as well. But more importantly, we narrow the knowledge gap by what we are doing. So eye transplant, it's the final destination, but we are learning and gaining a lot of useful information in advancing science.
Now, we talked, just like you said, about advancing science and what this would mean for patients that are blind and potentially having vision again. But what would it mean for both of you personally to see the world's first whole eye transplant? We all have kind of capstone projects in our career that would make our career and something that we strive for. But for you two being such leaders on this project, what would it mean for you to see that first eye transplant succeed?
Well, to paraphrase Neil Armstrong's comment, is one small step for man, a giant leap for mankind. This would be the outcome if we are successful in doing a whole eye transplant. Personally, this would be a capstone achievement for me, for anyone's career. It's that's how I would look at it.
Yeah, same here. I think if I were to see a functional eye transplant happen, uh, beyond that, I don't think I look forward to anything else beyond that. That would be the culminating achievement in my career.
Well, look, I mean, both of you, I want to say number one, what an incredible podcast. I think just the sheer concept of taking an entire eye and transplanting it, I can tell you up till about 6 weeks ago, I didn't even think it was remotely feasible. And then the more I researched for this podcast, and obviously now talking to you both, it's incredible the work that you're leading, the pioneer vision that you both have, and the team that you've assembled around you. And I think you guys summarized it best in that everyone's focused on the eye transplant, but it is a stepping stone for even greater medical achievements. And again, kudos to both of you for your vision, your teamwork, and obviously all the incredible hard work that goes into this project.
Thank you so much.
Thank you so much.
All right, guys, have a great day. All right, kudos for everything. All right, take care,
Thank
guys.
you. Thank
Have
you.
a good one.